All right. So today's implementation science working group, we're delighted to have Dr. Ruben Martinez, who's an assistant professor and acting associate director in the Bridge program in the Department of Psychiatry and Human Behavior at Brown. He'll explain a little bit more about the program as he gets going. And his research, which he'll cover in a couple different examples today, really focuses on leveraging equity-grounded implementation methods to enhance systems of care for youth and adults experiencing health and mental health challenges. Um, and so his talk will go about 30 minutes or so, and then we'll have questions for him at the after that. And so as a reminder that Danielle just put in the chat, and she'll remind us again, that you're welcome to submit anonymously questions through the Slido link. I will help kind of moderate those questions and raise them to Dr. Martinez when we get to that portion. And otherwise, once we get through this, we'll take questions through the chat or answering questions, but the Slido is sort of helpful to understand what people are mostly interested in because you can upweight from there. So Dr. Martinez, I'm going to pass it over to you. And thank you so much for being with us today.
Absolutely. Thank you for having me. I am delighted to meet you all and see so many new faces. Let me get my slideshow up and running. So today, I am actually going to be talking, everyone can see thumbs up. They can see the right thing. Okay, great. I'm actually going to be talking about practical approaches to prioritizing implementation barriers, which is a subset of methodology, a subset of the types of methods that we use a lot in our program. Just to tell you a little bit about where I'm coming from, you can scan this QR code to visit our Bridge website. In 2019, Dr. Ronnie Elwee started the Implementation Science Core in the Department of Psychiatry and Human Behavior at Brown. In the last couple of years, we rebranded to become the Brown Research on Implementation and Dissemination to Guide Evidence Use Program. Our mission, which you can see here, is to catalyze the equitable dissemination and implementation of evidence-based interventions into routine practice through collaboration, mentorship, and capacity building for future implementation scientists and practitioners. I myself am primarily a methodologist, so I work on right now 10 different NIH grants as a methodologist, doing every stage of implementation science across many different types of projects, and you're going to hear about a few of them today. Our group as a whole, we consult across the VA in Providence, the different hospital systems, so Care New England, Brown University Health, and also across Brown generally. And we also have partnerships that are across the country. So we work with a lot of different people doing a lot of really fun and interesting things. And I hope that we'll be able to form some new ideas together today as we get to know each other. So this work that I'm going to present, a lot of it comes from the Impact Alacrity Center. And so this is an NIMH P50, so a center focused on developing practical implementation methods. The MPIs originally were Kara Lewis and Shannon Dorsey, and then later, when Kara left for NHLBI, became Brian Weiner and Shannon Dorsey. So Brian really worked hard on the barrier prioritization toolkit. I'll give you a code here in a second, but we're going to focus on prioritizing barriers, which is a huge focus of the P50. So developing a practical methodology for doing this in a straightforward way. And I'll show you two different ways we can think about doing it. All right, so here is the toolkit. So if you scan, you can actually download it. It's free. I'm not making any money off of your scans and your visits to our website. It is good for us though to have more downloads than less, of course. And I have used this in several projects, and it's something that I will continue to use in most of the projects I have moving forward. And the reason for that is that prioritizing implementation barriers to implementation is a really challenging and important thing to do. Oftentimes when we do a barrier and facilitator analysis through any method, we're going to identify dozens and maybe more barriers, sometimes up to 80, 90, 100 barriers. And you might start to ask yourself, what am I supposed to do with all these? Am I supposed to develop an implementation strategy or set of strategies that's going to address all of these barriers? That is so overwhelming and not resource efficient at all. So we have to have a way of prioritizing these barriers and really identifying what are the impactful low-hanging fruit that we can actually do something about. And so there are a couple ways. I'll show you one way that's more quantitative, and that's really from the toolkit. And I'll show you another way that's more qualitative that we do oftentimes with our community partners. And we'll review 3 examples of this today. And I have 3 examples because they're 3 different stories, and they can just give you a sense for how flexible this method is. Any questions? Is it okay if I ask about questions throughout? Is that cool? Okay. No? Or should I just wait? We have 30 minutes.
Yeah.
Okay. All right. Sounds good. So the first one I'm going to, oh, actually, sorry about that. So here's what this toolkit looks like. I'll tell you a little bit about the toolkit, then we'll go into the actual studies. So when we think about prioritizing barriers, you might think about how important is this? And I think typically the way the criteria we've used to prioritize barriers has really been around how important is it and how feasible is it to address. And so we often think about a go, no-go zone plot where we have the upper quadrant being these are the most important and feasible things to address. But we might actually start thinking about expanding what we think about as meaningful criteria by which we can rate implementation barriers. So in the toolkit, there are several proposed criteria in here. We talked about importance, and I think the text for T-focus I'll talk about a little bit later, but importance refers to the extent to which the barrier affects the implementation outcome, the perceived effect. Frequency is how regularly the barrier impacts the outcome or the use of the thing, or is likely to impact it. Duration refers to the length of a time the barrier has been affecting that outcome. Addressability refers to how feasible it is to address. You could use feasibility or addressability. Timing, I think, is a really interesting one, which is there's 2 facets to this, which is the ability to address a barrier now or in the near future. Another way of thinking about it is actually, is this barrier going to be a barrier for long? So for instance, in one of the projects we worked on, one of the main barriers that clinicians had was that they needed this thing built into their health record system. Right now, that was a huge barrier, but they were about to adopt a technology that actually plugged into their electronic health record system. So it wouldn't be super fruitful to spend time strategizing about that because it just simply wasn't going to be a problem for that much longer. And then another criterion is equity impact. So if we address this thing or don't address it, what is the impact that it has on the equity with which we can deliver this practice? All right, so there might be even more, and we can talk about these. I love brainstorming new criterion, but there isn't really a right way to think about it or a wrong way to think about it. These are just some ideas of how you might do that, or how you might conceptualize what you prioritize and how you prioritize it. So the way that we have done it is that we've gone for a trivariate rating. So instead of the 2-dimensional go, no go, and plot, you sort of add a 3rd dimension on the back end. And so you're looking at what are the things that are most important, the barriers that are most important, most frequently coming up, and most addressable. So in that way, we can get just a little bit more specificity to pull out the barriers that are really important to address, that are critical to address and addressable at the same time. So I'll show you an example of that in a second, but this is what you've probably all seen something like this, which is the go, no go zone plot. And we're actually going to use this in the qualitative version a little bit later to demonstrate a slightly different way of thinking about barrier prioritization. All right, so the first study we're going to talk about is an R34 size study that was one of the signature projects of the Alacrity Center, which I led alongside Brian Weiner. And the purpose of this was to develop tailored implementation plans for implementing measurement-based care into community mental health centers. And so we wanted to pilot all of the methods that we developed in the Impact Center. So for those that don't know, measurement-based care is also called progress monitoring, but it's really just the idea that we need to collect routine outcome data, share that information with our clients in mental health specifically, and then use the data to make informed decisions and to collaborate and decide on the the direction of treatment. So that's really what measurement-based care is. It's really challenging and complicated to implement, even though many people say that they're doing it. So it's a really nice use case for some of these methods. I'll just tell you about what we did. So the other methods of the Impact Center, which we do have toolkits for almost all of these now, except design kits. So we did a rapid evidence synthesis, which is like a rapid systematic review, and that helped us identify the broad, like the base of the pyramid of barriers. What were the sort of constellation of factors that we might think about? But we really wanted to develop a plan that really leveraged contextually specific barriers, because the more specific our barriers are, the more specific our implementation strategies and blueprints can be, and therefore the more effective we think that they should be if they're more specific. So to contextualize the barriers, it was great to know that time was a barrier, right? Perception about, I don't have enough time to do measures. But what does that actually mean in practice? Do you perceive you don't have enough time? Do you actually not have enough time? We're talking about two different strategies depending on how you contextualize that barrier. So we did a rapid ethnography. So we have a toolkit for that as well. You can also find that on the website. The rapid ethnography gave us highly contextualized barriers along with this user-centered design method, which we've adapted for implementation called design probes or design kits. We have a toolkit forthcoming probably this summer and a paper about that I can share with you whenever that comes out. That gave us a ton of barriers. As you can imagine, we got so many different barriers from that. And it was really just, it was an exercise in just compiling them into one list. There were so many. So we had to figure out, all right, we have these contextually relevant barriers. How are we going to move forward with our implementation plan? To do that, we really leveraged this barrier prioritization toolkit. After that, we developed strategies, but that's not what we're talking about today. So this is what the sort of the survey looked like. And we had an implementation team. I didn't put that in here. We had a team of 6 to 8 people at every clinic. They represented people from records and registration, from administration, from the clinical team, the actual providers, and then also the supervisors. So we wanted to make this a representative group of people who could really speak to. Everyone sees barriers in different ways. So administration, as you know, might see a barrier in a very different light than a clinician and vice versa. So we wanted to have a really representative group here. So this is the scale that's proposed in the toolkit. So in terms of importance, we have not at all influential to very influential, frequency, never impacts to always impacts, addressability, not at all addressable to very addressable. And we actually pared down some of the barriers because, to be quite frank, rating 60 barriers on 3 criteria that's 180 items. That's a lot to do, right? So we wanted to get rid of some of the barriers that we knew simply we just couldn't do anything about in this project. For example, we knew we weren't going to change any policy around billing in this project. That was not the purpose of it. We had no control or power over that happening. So we just we know it's important. We're going to hold off on that. We'll talk a little bit about how you can manage that in a little bit. So here's what it looks like in practice. So we ended up giving them it was still a lot, but we gave them about 40 barriers to rate because we thought they were really important and things that we thought we could do something about. What came out of that was basically the way that we handled it was as practical and simple as possible. So we calculated the mean. This is just an example of what it looks like. We calculated the mean for each criteria, and then we did a conditional formatting in Excel. If this barrier is above the mean on all 3 criteria, then that is a barrier that's in the 3-dimensional go zone plot, right? So they're rated as most important, most frequent, and most addressable. So that's how we handled that. All right. Oops. So from there, I'm not going to talk much about, so from there, we developed implementation plans. We ended up with about 12 barriers, and our strategies were really able to, at multiple levels, address all 12 of those barriers, which we thought was really exciting. Okay, so that's example number 1 of prioritizing implementation barriers. And that's with a commute. So we did this all I forgot to tell you, we member checked the barriers. We made sure that they were accurate, but we were really partnered with an implementation team within a clinic to do this. So this is one example of methodologically how you can plug in this barrier prioritization. I'm going to show you a slightly different way of thinking about it now. So I'm going to get some coffee first because it's that time of the day. All right. The next study I'm going to tell you about is called the T-Focus app. So we at Butler Hospital, which is one of it's our biggest psychiatric hospital here in Providence, we have this really big problem where a lot of people who leave the hospital don't get connected with care. And there are a lot of reasons why that happens, but one of the hypotheses is that there just aren't people to connect them, and there aren't people checking in on them and making sure that they're okay and that they're getting to their appointments to follow up on, whether it's med management or therapy. So T-Focus is a mobile application connected with a coach. And so when people leave, they get connected with a coach. They answer some questions every once in a while, and they have a check-in with their coach every week. And that check-in is to ensure that they are getting to where they need to go. So the coach also kind of facilitates that appointment and makes sure that it happens. Ethan Moitra and Brandon Gaudiano are the PIs of this study. So when I came onto this study, they didn't have any barrier prioritization or anything built in. And what they were telling me was, we keep having these CAB meetings and we keep talking about barriers, and everyone's getting really sad because there's just like, nobody knows what to do about them. We just keep identifying more and more and more problems. What do we actually do with this? So when I came onto this, what I suggested was we basically develop an implementation blueprint for the next phase, leveraging the community advisory board. And the community advisory board has everyone ranging from like EHR specialists to payers to patients, people with lived experience. And so what we ended up doing was a much more informal, this was not part of an implementation study per se, but it's to prepare for an implementation study. So the idea was that we would do informal key informant focus groups with our CAB to identify barriers. And that's the CAB and our research staff. And so we were able to actually do a really quick, rapid, qualitative 1 hour focus group and about an hour and a half on the back end to analyze the data, to come up with a list of barriers that the CAB and the scientific, the research team had told us that they'd experienced. We went back and we member checked several times, both with the CAB and the research team, to ensure that the barriers were really getting at what we wanted them to get at. And we used the CFIR to categorize those barriers, the Consolidated Framework for Implementation Research, to categorize them into different levels. On next Friday, we are actually going to be prioritizing those barriers using Qualtrics. And the idea then is that we're going to take that, what we get from there, and we're going to develop strategies to be tested in the next grant. And what we're really focused on is some of the pieces actually that we didn't focus on in Nimble, which is that first study I told you about, because now we have significant questions about who's going to pay for this app. Where does it live in the ecosystem of the hospital? Who actually does it? Who are the coaches? These are all of the questions that we want to develop strategies for so that it is sustainable in the future. Because when the study was developed, it was not developed with those things in mind. But with leveraging these insights from this practical implementation method, which really takes a total of about 5 or 6 hours from start to finish, we're able to develop a really clear, logical plan for proposing for sustainability for the next grant and the next project. So that's really exciting. So that's way 2 of thinking about barrier prioritization. And then this is how we ended up. We did it all on Miro. I'm not going to show you the whole board, but we actually used Miro in real time. As we talked to them, we would get snippets of what they were saying. We would ask them specific questions. And we also looked back at another CAB meeting where they talked about the barriers. We then put them on sticky notes. We organized them into different domains. We didn't really worry about constructs because that wasn't super important. Like, we weren't super interested in whether it's attitudes and beliefs versus something else in the individual domain. It's like, we really just wanted to know the contextual level that we were working with here. And then from there, that's where we're now taking that information. It's in the form of a Qualtrics, and they're going to complete the Qualtrics. this upcoming Friday, as I said. So that's example number two of how you can leverage practical barrier prioritization methods. The third example I will tell you about is actually much different. So in this one, the PIs decided they wanted to use the same criteria: importance, frequency, and addressability. Those are the things that they chose. There are times where you may not want to go this more quantitative route. Maybe you want to go a route that is a little bit more engaged and a little bit more conversation and interpersonally focused. And I'm going to give you an example of that next. So this paper was just published. Allison Tovar, who is at School of Public Health here at Brown, is the PI, and this was funded in part by USDA. And so this was a project to develop an implementation blueprint for WIC. And if people are not familiar with WIC, WIC is a federal assistance program for women, infants, and children. Leveraging things like nutrition support and referrals to healthcare appointments. And so WIC, I'll tell you a little bit about how we did this, but Hannah Frank, who is the acting director of our program, and I really collaborated a lot on this project. And so they had their CAB, and the CAB helped us identify some salient interest holders. In this case, we weren't just interested in talking to people who had access to WIC and were using those benefits. We were actually also interested in talking to people who had previously used WIC but had dropped off, who weren't using it anymore. And we wanted to talk to people who worked with WIC, so the people who were providing some of those services. So we identified these salient interest holders, and we conducted semi-structured qualitative interviews with them based upon the CFER. And from this one, at the outset, the idea was that we were going to use a framework matrix rapid qualitative approach. So that means that we're taking the CFER, we're turning them into the a priori codes or the categories, and then we take the text we get and we organize it into those buckets of the CFER, right? So that was a rapid qualitative analysis. And then once we had those barriers, we went back and we prioritized them with the community advisory board. What was different about this is that instead of giving a quantitative, like a Likert scale metric, we actually did this all over a conversation. So I'm going to show you this next thing, and it's going to look really overwhelming because it has a lot of colors, but I'll explain to you how we got from where we were before to this picture. So this is what it ended up looking like. What we did is we brought in our community advisory board, and every person was assigned, every duo was assigned a different color. So Danielle and Julie got orange, Caitlin and I got blue, et cetera, et cetera. People would drag and drop them on this same go zone, no go zone plot. And then we would actually flip it. So the people who had blue got orange, the people who had orange got yellow, et cetera. And we would actually talk about if we were going to make significant changes to the barriers and where they sat in the overall plot, we would actually cross-talk about that and talk about why we changed it and why we thought that that was important. So this is a slightly different way of doing that. And this was similar vibes to the T-Focus study where we were developing an implementation blueprint using these methods. So that is way number 3. And as I said, you can check out that paper. We just published it. And the actual blueprint itself, it's been submitted to Rhode Island, and I believe should be available soon. I looked for it today, but it wasn't online. But the actual blueprint itself that has the barriers categorized and then the implementation strategies, we also went through after, and we did the exact same thing with strategies where we had people categorize how important and how feasible the strategy was that to address these barriers. All right, so that's example number 3, which is perfect timing. And I do want to end this by just starting a little conversation. Then I'll talk a little bit about the challenges at the end. But I'm curious about, for you all, as you think about using these in your project, there's this quantitative version, the qualitative version is like plugging it in at different places. What do you like and dislike about each of these configurations? Yeah, I see Alexandra's hands.
Yeah, I like the third one partly because you involve the community and you created a pretty accessible process to hear what the barriers are from their point of view. And I think that sometimes that can be a problem, that we think we know what barriers are, but when we actually implement something and no one takes it up, we realize, oh, maybe we didn't totally understand what it looked like from their perspective. So I like that. And the colored stickies, virtual stickies, just it kind of really makes the point so clearly.
That's great. I love the colors. It's my favorite. Any other thoughts about the quantitative versus the qualitative?
Yeah, one of the things I was thinking about was whether something, how you could, before we got to your third topic, which is how do you get to the point of being able to identify the barriers fast enough when time is of the essence and you kind of need to make a decision quickly. And so, I was imagining probably like ideally we want to do the surveys and do it relatively rigorously, but in practicality, what you proposed and what you're doing in version 3 is, I think, still more rigorous than many people actually do. So I sort of was leaning option 3, kind of liking it for the practical aspect while still maintaining some rigor. I
Mhm.
see Anne with her hand up.
Thanks. This was so much fun. Thank you so much, Ruben, for joining us today. I am a big, I loved number 3 because I love hearing patient voices. But I have to say that I did kind of like this quick and dirty quantitative way of version 1 where you actually score. That was version 1, right? Where you
Yeah.
score. And there's something just really nice about that. And it just depends on how much time you have. And I think if we could do the community groups and being able to hear patient voices. And you were talking, and I believe that's the one where you really wanted to chase down the patients that had not followed up with WIC to hear their
Mhm.
voices. I
Yep.
mean, that just takes an extraordinary, I mean, I'm like respectful. That takes a lot of time. So lots of respect there. But sometimes we don't always have that, which is like, I might argue that that slower road is a much more important one, but sometimes if you just need to get some data out, I'd love this like quick and dirty. Well, it's probably not that quick, but 40 items, 3 different, one to 3 on them. I mean, you need to get somebody to attend to it, but if you need to get some quick data, that wouldn't be a bad way for certain populations to be able to do it. So anyway, thank you so much. It's been fantastic.
Yeah, that's great. And to your point, the T focus example number 2, we actually have only spent, I would say, a grand total of, it's not budgeted into the grant. Like we're just leveraging the existing cab meetings and a grand total of about 6 hours between myself and my RA. And that's pretty much it for number 2. That's all we've done. And we're getting so many fruitful insights out of it. All right, so I'm going to ask one more question from you all because this is the most important thing about this. I think to your point is we have to tailor all of our methods to the time we have, the people that we're serving, the voices we want to hear, the money that we have. And I think there's a certain amount, especially when you're engaging people in a participatory method like this, there are power differentials. There are challenges interpersonally. You have leaders sometimes who are sitting in the room and that's not always the best thing. So I'm curious what you all foresee as some of the challenges in using some of these methods. And I'll highlight some of my experiences after this.
I'm not sure how to put my hand up. Sorry. But I was, thinking through others' comments as well. And one of the things that I was thinking about was, as you mentioned, sort of like when you're engaging a whole variety of stakeholders, how some might be the loudest voices, but might not have the most important information, and other quieter voices might have extremely important information. And so I'm not sure which one of these actually balances that the best. On the one hand, looking at it purely quantitatively kind of takes everybody's perspective equally. On the other hand, if you, have one stakeholder that rates something as completely infeasible and doesn't have a way to sort of like explain the details of that, that might actually be a really important, comment that you wouldn't capture if you're looking at it purely across means of different stakeholders. So that's one of the challenges that I foresee is sort of balancing that array of perspectives.
Yeah, it's a great point, and that is a big challenge. And I saw someone else had their hand up too. Maybe Colleen.
Yep, that was me. This was a fantastic presentation. Thank you. I actually had a very similar thought to Nancy, which is why I put my hand down. I just imagine that it'd be very challenging to gather the right balance of perspectives, both on the receiving end in terms of the key audience that you're trying to reach, but also all of the key players within the implementation process. So trying to make sure that that's well balanced. Yeah, but this is great. Thank you.
Yeah, absolutely. And to that point, I think, we might get this go zone plot, and you might have all of, this cluster of barriers. That's not your hard and fast body of barriers, right? You can always go back and pull things in that maybe were rated infeasibly, but it turns out that clinicians don't think it's feasible to address, but actually administrators do, and vice versa. All right, so I only have one more slide, which is really to talk about this. And so this is what we've experienced, and this is kind of, I'm pooling some of the collective experience of our impact group and then our group at Bridge here. It's really hard to meaningfully collapse barriers so that they're concise enough for people to conceptualize, but not so oversimplify that they are meaningless. And the member checking is really important, and going back and saying, is this the right level for you to think about this at? Like, does this meaningful enough to you as a set of barriers? I think that's really critical. And also to that point, barriers have to be sufficiently defined for you to do this, because I've consulted with groups who've come to me and said something along the lines of, well, we didn't have a lot of differentiation in our barriers. Everything was important and everything was addressable. And I asked to see their barriers, and the barrier was like stigma. Like, stigma means nothing. I don't know what that means outside the context of how it operates. Who is experiencing the stigma? What does it mean? What's the stigma towards? There's so much to understand there. So I do want to say that you have to have sufficiently defined barriers to be able to do this in a really efficient and effective way. And then the final thing that I want to just highlight is that I think it's a really beautiful thing when you can facilitate discussion after you do the quantitative piece, because what you end up finding is that, as you all probably know, sometimes the nurses and the records and registration people don't talk to each other about processes that are challenging, and they may not talk to the integrated behavioral health clinician or the physician. And the crosstalk that you can get as part of this, that illuminates dynamics for you as an observer, but also illuminates challenges to help develop even more of this effective strategy, can be a really powerful tool. So with that said, I know I'm over time. Just curious if there are any questions. Stephen,
That was fabulous. Thank you. Yeah, Steve, please.
Of course, I have a question. Great presentation, Ruben. Really nice work. My question was about this, looking at the toolkit and looking at its focus and the wonderful quadrant that you have where, the ideal is, high feasibility and, and a barrier that's attainable and salient and changeable. How do you deal, and it seems to me that most of what you're focusing on appropriately is contextual barriers. How does this model incorporate problems in the thing? And obviously that's where the whole science of adaptation comes in. But, I'm always, having been in this field for, maybe centuries, I don't know, a long time, the initial concern was with barriers and overcoming those, and that there's something wrong out there that we need to fix. Increasingly been interested in the idea that maybe the thing that needs to be fixed is the thing. That it wasn't really designed, it's too complex, it's too expensive, it's too this, it's too that, it's not really easy for uptake in the setting. how does the barriers framework, it's not a framework, the prioritizing barriers kind of toolkit take into account if the problem is actually not as much in the barriers, but in the actual evidence-based practice and its need to be reformulated, adapted, or maybe even thrown on the trash heap. What do you think?
Yeah, it's a great point. And I think it goes actually back to the way that you synthesize the barriers to get to what you prioritize. And so for what we did, we really tried to focus on organizing. We wanted innovation factors. So what was the stuff about the thing that we need to change? But to your point, there are always things about the thing that you probably can't change, or maybe that change makes it not the thing anymore, as I think to your point. And I think one of the areas we saw practically where this was really challenging was when there were barriers related to the electronic health record. And sometimes with the EHR, you got a team that's right there, that's on it. You have a team that's bought in, they have the resources to program in the changes that you need. Sometimes they don't. And so part of it is also there's a certain amount of to me at least, there's a certain amount of give and take of we know this thing isn't perfect. We have to acknowledge that there are challenges here. And at the same time, if there's, for instance, a like a mandate to use a specific system or thing, how we have to do what we can. So that's, I think, the power of getting to that low-hanging fruit is like, okay, well, we acknowledge we can't do, and like we did that explicitly. We said there is nothing we can change about this specific part of the system. We wish we could. So we're going to try and do everything else we can to support you around that. I don't know if that answers your
That's a
question.
great answer. Thank you. No, and I think this is a really great contribution. The only other quick comment or question was the extent to which the model accommodates, which is more of a sliding scale to some extent of these variables. And I see that it's a continuous measure, but it kind of weighing feasibility with some sort of, again, a barrier that can be removed that's mutable versus I saw one of the barriers was funding and reimbursement. Good luck with it.
Right.
As like it always comes up, it's always present in the background. The funding and reimbursement and financial barriers often supersede and often really overwhelm everything. And I was just wondering how you incorporate that.
Another great question. And it goes to me, the ways that we handle this most effectively is to scope the prioritization for the thing we want to do and the next step, which is, so for T-Focus, we have an opportunity to actually to lobby and to figure out how we can get payers to pay for this thing and to incorporate it into the health record system. So it can be something you can bill for potentially. That's something we want to explore doing. And so we're going to put that on the table as a possibility for maybe that's the next implementation study is we do some sort of like policy payment dissemination kind of study with it. And so if that's on the table as a potential solution, I think it's worth having that barrier there. On the other hand, where we were measurement-based, so in Washington State at that time, measurement-based care, you couldn't really bill for doing any of the measures. And so for us, it wasn't on the table as a solution. So we knew it was important. We knew it was going to be helpful if it was done, but we also knew at that time there was nothing we could do about it. So we left it off the table. Thank you.
Yes, you're welcome to ask your question. Thank you.
So great presentation, and it's my question and comment actually is in the intersection of what Steve just mentioned about the financial piece, but it's kind of a broader perspective that I'm going to look for the importance and also the addressability. Just looking together. When you ask all the stakeholders that there may be some of the barriers, not only financial, some other barriers, that may be addressable in a really great strategy, but creating a strategy is another thing. You need to have a lot of background experience and also thinking process. It's not about like generic strategy development.
Mhm.
And there may be some more than one strategies to address very important barrier, and it may not be visible or obvious to the stakeholders right away. And
Mhm.
it may take very important barriers that could be addressable through multiple strategies and need to be addressed out of table through this methodology. Do you have any concerns around that, or how do you handle this?
That's a great question. That came up actually about a month ago in a meeting. And what I think my concerns about that are if you end up in a situation where the barriers that are in your go part are there's just not enough of them. Because then people are saying, yeah, these things might be important, but they're not feasible to do, or they're not addressable to get around. And in that case, that warrants a follow-up discussion where we actually would provide some really basic knowledge around actually, here's kind of like a menu of strategies and how we think we can actually do something about these things. And so then you might revisit a little bit of that prioritization. And I think to the point that Nancy and I think Colleen had, when we get this table, this plot, we're not holding that as okay, that's it. Like we're definitely going to go after just these. We're using that as it's a signal for what feels important to people, what feels salient, and what we can do something about. And so if we don't have enough in there and it feels like we're missing some really important things, we also use our judgment as researchers to then say, actually, this thing was not you rated it as not feasible, but I actually think the strategy we're developing here can impact this thing too. So it kind of gets pushed up into that quadrant or that section. And I think to your point, this might answer some of your other part of your question and your wonderful point about people may not know what's feasible to address. They may not know what these strategies are. What we did after in Nimble is we used a participatory causal pathway diagramming method where we really, we helped develop causal models with people, including what was the barrier, what was the mechanism of the strategy, and then our proximal and distal outcomes. And that's how we developed our multi-level implementation strategy, was also with our implementation team. And so that did also help them think through back to any sort of other barriers we talked about in past meetings. So I don't know if that gets at answering your question. It's for sure is a limitation, but something definitely we can do something about.
Great, thank you.
There was a question that was ranked a couple times in the Slido that I'm going to make sure to ask in the absence of kind of other questions as people think of them. I think for your second study, which we spent less time actually reflecting on, I think that's the T-focus one.
Yes, T-focus.
Can you give a little more information on, you mentioned you're going to use Qualtrics for the barrier prioritization. Sounds like there's some interest in understanding a little bit more about how that will work.
Yeah, great question. So we developed a new survey, and so before we actually put the items into the survey, we've gone through 2 or 3 iterations of getting that sort of like that bite-sized barrier piece right for them. We just have so there's a matrix. I can actually pull it up, but there's a matrix that we have put together. And we're going to have them rate on importance first.
Oh, are you sharing it?
I will in just a second.
Oh,
Yeah.
okay, sorry.
I want to pull it up. So we're going to have them rate on, so each barrier on it, we kind of went back and forth. Should we do barrier, importance, frequency, addressability, barrier, like each one on all 3 criteria first, or should we do all on importance, then all on frequency? And we decided for this one, with PI's input, that we would do importance first, and then they're going to rate it just like this. But this doesn't tell you what you need to know, right? Because when it gets pulled out onto Excel, we have to do something with it. So we're actually going to spend the first 30 minutes of the meeting with them rating these, and this looks like a lot because it is. And then once they rate them in real time, my RA and I we're gonna go into a breakout room, and our PIs have a other activity or thing that they want to talk to the cab about. So they're gonna kind of like keep them busy and doing important things while we go in, do what we need to do in Excel, and then we'll come back to them in the same meeting with the prioritized barriers and then member check from there. So we try and do everything as practically as possible because I don't like to super over scientify some of these things. They're really good practically as is.
I have a relatively minor question since you flashed that came earlier in the presentation. I was intrigued by the choice of the 4-scale Likert, actually, the 4-point Likert. I assume there's some thought process behind that you'd probably have thought deeply about in recommendations, sort of forcing people not to choose the middle, maybe. But if you could speak to that a little bit more, that jumped out to me early on.
So I will say this was a Brian Weiner decision. So I cannot directly speak to the 4 points. I think that we wanted to have no neutral response option. I think that's what he was thinking of, probably. So force people's hand in one way or the other. You can email him though. I'm sure he'd be happy to answer a question or two.
Fair. I know the AIM measure that he's published on 5. That's why that wasn't the answer I was expecting. Okay. Great. Yeah. You have another question? We have time for a couple more, I think. Maybe 2.
Yeah, if there is other people to ask, they can go first, but if not, I can. Okay. So my question is that, when you look at the barriers, also there's a kind of the other part of the flip side is the facilitators.
Mm-hmm.
It's kind of like barriers, facilitators, and strategies. So, and sometimes even like kind of a fluid balance between the barriers and facilitators. Depends on where you look from, like which perspective you may make some of the barriers like facilitators versus barriers. So, what do you think about it? Like, have you thought about just putting this into a context, or just really keeping this matrix as only barrier focused?
That's a wonderful question. And this is in my mind, in our experience, I would say in my experience, facilitators are extremely helpful. Oftentimes facilitators, not always, but oftentimes facilitators end up being things that one clinic has that another clinic doesn't have. And not always do you see the ability to leverage that resource. However, those facilitators are engaging some mechanism, right? So it might be a facilitator that, well, some of our clinicians are Spanish speaking and other clinics don't have that thing. It would be amazing to do that, to develop a strategy that included hiring Spanish speaking clinicians. That's not always a feasible thing to do, but it is engaging some sort of mechanism for the strategy. And so I think in my mind, it's important to keep facilitators in mind. And I do think you could do the exact same kind of process with facilitators. That's just not something that we wanted to focus on overcoming the barriers rather as opposed to leveraging the facilitators. With that being said, we also kept in mind how we could leverage facilitators when it was appropriate and feasible to do so. So it's a really good question. And I think there's an open question generally around the role of facilitators and how you leverage them effectively in implementation work, particularly to engage the mechanisms I think that those facilitators engage. So I think that's a great question. It's really thoughtful.
I think that makes sense because sometimes the way we think about facilitators is the kind of the segue into implementation strategies, like how would we actually go about implementing it? So it's almost like it would jump too far ahead to sort of request people to weigh in on those types of things.
Yeah. But we would perhaps ask folks if there is a facilitator that feels really salient and feels like something that it you might even call it. I think a lot of facilitators are also, in the words of like a causal path diagram, they're also kind of sometimes preconditions. So there are things that must be in place for something else to happen. Like for you to use electronic health records, you have to have the electronic health record in the place, or for you to plug something into the EHR, your EHR has to be able to be plugged in too, right? So I think some facilitators are also preconditions, and they're just things that must be there for a strategy to work in a specific way. So we might even ask the question of, if this is a facilitator, and that facilitator is a precondition, can the precondition be met in this other clinic over here?
Yeah, and speaking of causal pathways, there was a question, Slido, asking you to speak a little bit more to the participatory causal pathway model you talked a little bit about. It might be helpful to sort of contextualize
Of
some of the things
course.
you've been talking about.
We even have a toolkit for causal pathway diagrams. I will admit it is hefty. It's a lot to take in. There is a really complicated way to do this and a very much more simple way to do this. I'm going to try and pull up an example here, just to show you what it looks like. So we use, again, like Miro or Lucidchart, any sort of group diagramming. And so if you don't know what causal pathway diagrams are, they're really just a type of logic model. They look similar to driver diagrams and other diagrams that we use. This is for a grant application, I think, that I adapted for something else. But so there are all, this is, so the stem is, you have a strategy. The strategy engages a mechanism to overcome a barrier. That barrier leads to some sort of proximal outcome, so something that happens near, after, and then there's the distal outcome.
I think we see your question slide.
Oh my gosh. Hold on just a second. I always get confused. Okay, this should be right. There?
There we go.
Okay, sorry about that. Thank you for telling me. So, so we have the strategy, the action to address the barrier, how or why, which is the mechanism. So how or why does that action overcome the barrier? How does it help us? Does it increase knowledge, self-efficacy, collaboration, whatever that is? You have your proximal outcome, so an immediately or close to immediately observable change in that malleable factor, and then an outcome. And so this was just an example I made to show that we would be doing participatory causal pathway diagramming. In reality, what it looked like was something like this, where we brainstormed together. This is a lot. We brainstormed together strategies, and we actually had a menu of strategies for the barriers that we thought would be effective. And I'll zoom in just a second. And what we did is we said, okay, so we want to feel compelled that our strategies are going to be helpful, because what we don't want is to, much like what happens frequently is like people make a decision about a strategy and how you implement something because they think that's the right thing to do. Someone had referenced that earlier, when in fact their understanding of the barrier and the mechanism is not compelling. So our therapists aren't doing progress monitoring measures. I heard that it's because they don't feel like they have enough time. I'm going to send them an email and tell them how important it is. That's not engaging the mechanism that you need to engage to get your therapist to do more progress monitoring. You're telling them it's important when in fact the barrier is they don't have enough time. And so there's a mismatch, right? And this happens a lot when we see people develop strategies, is that they're not causally thought out of how we're actually going to be doing things. And that we want to know that our strategies are compelling. And so what we ended up doing, and this is so messy because we did this in the moment, is we gave an example. We talked to them about, we gave an example of a bad strategy, and then we gave an example of a well thought out strategy. And then we actually talked through, all right, what are the strategies we can do for this lack of centralized guidance? We brainstormed all the strategies we could that we felt were compelling initially. We talked about the mechanisms we thought they would engage. And then we actually, because we didn't want to think about proximal and distal with them, we really just thought about the ultimate goal is to increase the use of progress monitoring tools. So after that, we actually went through and voted, and we said, which of these do you actually find compelling? Because it's okay to develop a strategy that's not compelling. We develop them all the time. And so this was the process that we went through to develop our multi-level implementation plan with completely collaboratively with our partners. So it takes a little bit of doing. And again, there's a very complicated causal pathway diagram that has the preconditions, mediators, moderators, proximal effects, distal effects, et cetera. So it can get really big. And then you can also model it to actually show them multi-level strategies and what the mechanisms they engage and then the barriers they overcome. There's a really great paper that Brian did. It's called like Changing Hearts and Minds, where they actually develop a really nice causal pathway diagramming for a strategy to help change minds. That's sort of like the mechanism that they wanted to engage. So really interesting stuff. And Optic, which is the sister center to Impact, which is funded by NCI, which I think is maybe over now. And then there's a mechanism, implementation mechanisms, R01, that are all sort of housed in the same place. And we're trying to advance some of that thinking around causal pathway diagrams.
That was fabulous. Thank you for a very thorough answer to.
Sorry, that was a lot. I gave you everything.
You're like, I can sense the enthusiasm. Well, that was fabulous. Thank you so much for giving us a really practical and informative talk. And just to highlight for everyone, you are local, you're at Brown, that's basically local. I keep being surprised how close Providence relatively is. So hopefully this inspired some opportunity for collaboration. And I just want to highlight some of the things Danielle put in the chat, which is that we have just opened a brand new program that we're running under the Harvard Catalyst auspice, which is designed to help people prepare for applying for K Awards specific to implementation science, because as we're writing K Awards, those can be different from other types. We'll run it throughout the summer. So please apply or reach out if you're interested. And we're also looking for work in progress presentations for our May implementation science working group session. So please reach out to Danielle. So yes, thank you. That was fabulous. And there's a request for your email address. So thank you for providing that.
Put it in the chat.
Awesome. Yeah. Okay. Amazing. Thank you so much. It was really great to have you with us.
Yeah, it was so fun. Thank you all.